Okay, I think we're ready to go. So welcome everyone to the Össur sponsored industry symposium. Once again, we would all want to be together, and hopefully next spring we will be. But thank you all for signing on to this important program and showing your support for the AMSSM and its unbelievable academic program in this virtual annual meeting one more time. So I'd like to introduce our speaker. I'm Marge Albaum. I'm the Director of Clinical Research and Fellowships for Össur Americas. I know many of you, I've seen you at meetings and look forward again, like I said, to those hugs next year. But we have a great speaker tonight. Dr. Anish Garg is a board certified, fellowship trained, non-surgical sports medicine physician, treating patients across the age span at the Houston Orthopedic Clinic in Nashville. Dr. Garg serves as team physician for USA Hockey, and in a short time will be headed on the road for hockey tournament in their bubble, and USA Soccer, and has served as team physician, medical director, and tournament physician for several high schools and college teams. Dr. Garg serves on the sports medicine teaching faculty at numerous universities and hospitals, and is known as an outstanding speaker nationally and internationally. He's certified in impact. His added specialty skills and procedures include orthobiologics, PRP, 10X, ultrasound guided injections, exertional compartment syndrome, and non-surgical fracture care. The thing I love about Dr. Garg, and I know you'll feel the same, is his practical, no-nonsense approach to trying to solve the problems that you see every day with your patients. And with knee osteoarthritis, as this is just growing. And he has so many resources and so much knowledge to try to build that perfect individualized protocol with all the tools that are available to him and to all of you. And he looks forward to sharing that in his lecture tonight. And I will turn it over to Dr. Garg.
Margie, thank you very much for that. It's awfully kind. And yes, I can't wait to give you a hug in person again sometime soon. And thanks to AMSSM for allowing us to do this and accommodating. And I'm excited to talk to you guys and see familiar faces and names. And let's get after it here a little bit. So this is one of my favorite pictures, just the surgical versus non-surgical approach to knee osteoarthritis. So we're going to talk quite a bit about different options we can do, certainly things that I use in my clinic, and we'll have ample time for questions and answers certainly at the end as well. Some disclosures: I'm compensated by Össur for this lecture. Everything in here is based on my personal experience, and really just these are my opinions. And so just a little bit of background, and Margie touched on this. I'm actually leaving in 10 days to go to Dallas for the Under-18 World Junior Championships for USA Hockey. So just some background on me in terms of the type of athletes that I take care of, both as Margie said, spanning the age range really. But the biggest thing here is everybody's an athlete in my clinic. It doesn't matter if it's Krav Maga, it doesn't matter if it's track and field, it doesn't matter if it's a little bit of low jumping, it doesn't matter if it's boxing or wrestling, it doesn't matter, even age, regardless. Bodybuilding, hoops. My question here is, which hoop are they going at, because the basket's behind them. So that struck me on this picture, but really anybody. This is Ruth. She was 100 years old in 2009, competing in master athletes in Olympics and winning a gold medal. So really we have athletes from every age range, and it's about how do you get them back to doing what they want to do. So it doesn't really matter. And arthritis, especially osteoarthritis of the knee, is booming, and something that needs to be taken a look at in terms of what we can do better in managing and treating that. So if you look at more than 43% of adults with doctor-diagnosed arthritis report limitations in their usual activities. And you're starting to see from a cost standpoint how much this is really affecting in terms of the medical care and how much you're going to spend on osteoarthritis. It's $185 billion business, if you will. Insurance is paying roughly $150 million, and patients are paying out of pocket $1 billion. And patients are paying out of pocket over $26 billion. So not only is that money being spent, but then you look at earning loss in terms of actual production due to osteoarthritis is an estimated $80 billion a year. So if you think about this, and even when I speak to work comp or we talk to other avenues and say, how do we get your athlete or your worker or your patient back to doing their work so you don't have to have somebody cover them, have to pay overtime and do some of those things, and just the burden that it becomes down the line. I mean, even for, imagine for state and tax workers and things like that, what you're able to do if you're able to manage some of these things more efficiently and actually help out where you're not losing $80 billion in earning loss per year. And that comes from us, right? As a physician, how can we make an impact in our community? And this is something that we can do certainly from an arthritis standpoint. It's the most prevalent form in the knee, and it affects the medial compartment more so than the lateral compartment. It's affecting 20 million adults in the US. This has doubled over the past decade. I know we've had new literature come out, and this is more than doubled in the past decade. It's more common in women, and obviously the prevalence increases with age and has some occupational risks along with it. For this slide, the reason I want to show this for you, it's if you look at the prevalence of knee OAs comparable to something in internal medicine or something just in general medicine, it's comparable to heart disease. So if you look at how much we pay attention to heart disease in the general public, in general medicine, as internal medicine doctors, family physicians, ER, pediatrics, PM&R, whatever, this is something that is comparable to this. Prevalence in knee OA is greater than diabetes. How much time do we spend as primary care physicians making sure we address hemoglobin A1C, making sure we're up to date on all these things from a diabetes standpoint? So you look at prevalence similar to heart disease and diabetes, and then on top of this is poor social function and physical function as well. So something to really consider in terms of from a sports and orthopedic standpoint, as the sports medicine world, having the equivalent of heart disease and diabetes, this is something that we need to make sure that we're up on what we can do to serve our athletes in a more efficient manner. When I teach, I harp on anatomy for my students and residents, and so the big thing here just is for the why is the medial side affected more. The medial meniscus is attached to the MCL and makes it more rigid, so any disturbance and from a motion standpoint, you're going to get more of that disruption in the medial meniscus than you are the lateral meniscus because of that rigidity. The lateral meniscus is not actually attached to the LCL. There is some more pliability to it, and that's why it's less affected in that regard. In terms of innervation and vascularization, it hurts, right? In terms of when these guys have meniscus tears, degenerative meniscus tears, you're looking at these innervation zones, peripheral, medial, and central, and you're also looking at the vascular zones. And this is where you can try to find whether or not you can repair these, depending on if they're in the red, the highly vascular zone, red-white, or white-white. And this is what you're looking at here mostly. So the meniscal horns are richly innervated compared to the remainder of the meniscus, which is why you'll see these tears end up being more painful when you've got an anterior horn or a posterior horn tear. These are the ones that tend to be more symptomatic and cause more mechanical type symptoms as well for the athletes as they're coming through. Okay, so now we have a little bit of anatomy. So what's the biomechanics of the medial knee OA? So during the stance phase of walking, external moment on the knee forces the tibia to rotate medially. So then you get ground reaction force affecting the medial aspect. And when you adduct the knee, this actually increases the compressive force on the medial part of the knee. And so from a pictorial standpoint, you can take a look and you can see the knee adduction, and then you're increasing that ground reaction force, and how you look at the medial compartment and sort of the varus formation, what ends up happening when you have medial knee osteoarthritis. This is what ends up occurring in terms from a biomechanical standpoint in the knee as you go through the walking and the stance phase, and this is what causes that compression on that medial side. From an imaging standpoint, you can take a look at the progression in terms of the types of grading from an osteoarthritic component. And as you can see, just moving from left to right as the severity continues to increase in that regard. And just an easier picture to depict, you look at the normal joint space, and this is something that I make sure that I show all of my athletes, all of my patients, making sure they have an understanding of where their pain is and why they're having it. And so I tend to show them a normal joint space, and I show them the loss of joint space here, and try to impress upon them this is the reason why they're having the pain and why they're able to localize it, certainly on that medial joint line. Early onset of osteoarthritis. Now, this is generally going to happen post-surgery or trauma-related. So this is something that we're starting to see a little bit more of, is early osteoarthritis in adults. And then you end up getting the degenerative as you get older in age. And so as the master athletes, as we continue with them, and as healthier individuals start to be active longer, we're going to start seeing a lot more of this degenerative cases. Even if you're looking at the climate that we're in, if you think about this, everybody's been deconditioned for a year for the most part. And then as you start to increase your activities, you're going to see a lot more of arthritis flares. You're going to see a lot more of people itching to get back, and what can you do to help them continue being in motion? And we'll talk more about that as we go through. So Ruth says, stay with me here. We're going through this, and who's primarily responsible for treating and managing osteoarthritis? So this isn't just for sports and orthopedics. This is also for those that are in rheumatology, that are in primary care, that are able to recognize this and say, okay, this is osteoarthritis. Maybe there's something I can do, certainly in my office, that can certainly help with this. So you look at this, primary care physicians represent almost 50% of those that are responsible for treating and managing that may not have a sports and orthopedic specialist at their disposal. So that's something to keep in mind if that's something that you have, is certainly in your area, if you don't have somebody with my background or any of my colleagues in that field. So what do I do in clinic? Really, it's conservative treatment as we look. I try to be as aggressive as I can from a non-surgical and conservative standpoint. So we know the anatomy and the mechanism. We know, the other thing is to know what my patient's expectation is, right? What's the athlete want to do? What are we trying to get them back to? We assess their motion and their symptoms, and we know our options. So we look at different things like Tylenol and weight reduction, right? Lifestyle changes is the first thing we always talk about. We augment their activities. A lot of times I tell my residents and students, rest is not the right answer in my clinic. We want to augment their activities. So sometimes they are overemphasizing one thing and underemphasizing something else. So we want to keep their mobility, prevent their stiffness. So we send them to physical therapy and exercise, keep the range of motion, strengthen muscles, improve proprioception. You reduce pain while improving function. How do you go about doing that? One of the things here is, this is the thought process in my clinic. And you look at, as we talked about, corticosteroid injection, hyaluronic acid, topical agents, and bracing. And that's really the big thing for me here that's been a big help, is part of my six-pack, if you will, is that we standardize having them try the brace. And part of what's really wonderful is they're able to try it, and if they're not satisfied with it, and Össur does a really good job of being able to work with the athlete, with the patient, in terms of coming up with a good solution in that regard. But this is, rather than opting in, we start everybody on this to see if that's going to make a difference for them. And then we've had really, really good feedback in that regard. So as we go through this is the same thing that we look at from a 3 to 6 marker from a month standpoint in terms of corticosteroid injection, hyaluronic acid, but the bracing and the unloading braces are part of our standard protocol right from the very get-go, right from the very first visit they come through here. What are our current prescription patterns? So this is another thing that we look at, is how do we manage sometimes over-medicating, and is there something else that we can do rather than just prescribing medications? So if you look at current prescription patterns, roughly 94% are using medications or really left untreated. you look at 6% from a surgery standpoint, and you look at something that I think is criminally underutilized, which is bracing and non-invasive realignment. And this can delay and prevent for future surgery. There's minimal risk, obviously. And I think it's just from an educational standpoint, which I'm thankful that we get to do these types of lectures to increase awareness and increase education, and really the simplicity of it and how much it actually can make a huge impact. This is the brace I use most commonly in the office. It's the Unloader 1X. It's been fantastic. We're able to actually use the counterforce system involved to be able to gap the joint and be able to sort of increase the joint space as they're wearing it. So, well, what's the effectiveness of this, right? So the effective unloader bracing on clinical outcomes in articular cartilage regeneration following microfracture of isolated chondral defects. So it's a randomized control trial here, and we're going to take the effect of unloader bracing on microfracture and cartilage defects and be able to extrapolate into what we can use that from an arthritis standpoint. So the purpose is whether to decide if an unloaded brace can increase the thickness of the cartilage and regenerate after microfracture fracture surgery. So they looked at a couple of things here where they want to increase the repair tissue thickness, volume, the T2 signaling on MRI, as well as multiple questionnaires to evaluate decrease in postoperative symptoms. So 24 patients underwent this trial, and they were randomly assigned, and you're able to see the intervention group again using the unloading brace after the non-weight bearing for the first 8 weeks, which was consistent all the way through. What ended up happening was that the unloading brace repair tissue is greater than the no brace volume and thickness at 12 months, and the cartilage thickness in the unloading brace at 24 months. And so that's on the objective side, sort of in that regard. And then if you look at the positive correlation of wearing the brace, improved 6-month symptom score of the KOOS, and as well as quality of life, as well as the Tegner, you're actually able to look at the score changes from baseline to 6 months. So you look at the clinical outcomes that were most notably at 6 months, 12 months, and 24 months. And this is very, very new information as well. And this is something that just sort of recently came out. So something I encourage you guys to look into. But this study found a significant midterm increase in cartilage repair tissue thickness following unloading bracing in patients that were recovering from microfracture for isolated chondral defects. And you think about it, this makes sense in terms of how can this help us with osteoarthritis? Absolutely, it can. If you think about it, you are trying to unload the medial compartment where you're getting that friction and you're getting that pounding, as we talked about with the ground force reaction. And how can we extrapolate this? Well, that's exactly what they're trying to do in this microfracture study with the isolated chondral defects, that if you're able to offload it, you're going to decrease that pressure on there and allow for some of that healing to occur. And it's not just this study too. I mean, there's other ones. If we look, there's another one in 2017, unloading brace is a cost-effective method to bridge and delay surgery in the unicompartmental knee. So unloading knee brace are cost-effective, especially for unis. The unloader brace has benefits in the National Health Service for capacity, budget, waitlist duration, frequency of surgery, and certainly reducing the required severity of surgical intervention. So this is something else that can be augmented as we go through. And again, same thing. Can this help us with osteoarthritis? It can. We look at the American College of Rheumatology, and in 2019, they're making a strong recommendation for tibiofemoral bracing for the tibiofemoral knee osteoarthritis. So this is again something that is going to be helpful not only from a symptom standpoint, but from a functional standpoint as well. So that's something that's again going to go through as we talk about this, that bracing can actually augment quite a bit in terms of what we're doing. One of the big things that I wanted to talk about also was expert consensus protocols that were convened. So Össur convened a global panel of over 40 experts in orthopedic disciplines in London in 2019. And so the goal of this was to make recommendations for 3 different treatment objectives: preserving cartilage, maintain moderate to high activity level, reduce pain, maintain cartilage and improve activity level, and reduce pain and keep your activity level. The reason why this expert consensus is so critical is it's the first time protocols have been based on patient activity level and expectation. So this is something that's very unique and something that you look at where they're clearly trying to define approaches for diagnosis, conservative treatment, comprised of the core treatment, including biomechanical, pharmaceutical, orthobiologics, and other treatments. So these protocols help to clearly articulate the multimodal treatment guidelines, taking into consideration patients' perspective and expectations. Again, this is why this is so critical in my mind, is that this is the first time these protocols have been in place and addressed based on activity level and expectations from the patient perspective. It's an excellent resource for you guys to be able to look at. I know this slide deck is going to be sent to you guys, so we've included a link here for you to be able to, it goes right to it, and you can see the 3 different protocols and the examples that have gone through. It's a really good read, really informative, really easy read. So I highly recommend you guys read through that and really familiarize yourself with it, and be able to talk to your athletes about it, and to be able to say, you know, which one of these do you fall into? How would you like to proceed? It really involves your patients and educates them quite well on that as well. So we go back to, will this actually help us decrease medication usage? I mean, if you're able to look at this, there was a randomized control trial out of China comparing the short-term effects of meloxicam, which is what I use in the office, on Loader 1, and a combination of NSAIDs and Unloader 1 in 36 osteoarthritic patients. They actually demonstrated that at week 12, the Unloader 1 is superior versus medication just alone. So if you're able to sort of combine and use that versus just using medication, you can get a better outcome with your athletes. So something to consider here as well in terms of what this is going to do. Even from a WOMAC standpoint, you're getting a 16-point increase, a 16-point improvement on the WOMAC scale as well. So this is going to be helpful across the board here. All right, we're almost there. We're almost there. The big thing for me and my athletes is keeping them moving. We talked about this, that we don't like to rest them. We want to augment their activity. So the reason why I have had such good feedback and why I like using this brace quite a bit is this 3-point leverage system. It acts like a counter force, and so what you're actually able to do, you're able to put pressure above and below the condyles, opening up and gapping and unloading the affected compartment. And I think that's really the big thing here, is that you're gapping that joint and allowing for increased function and mobility, which is again going to keep them moving, which is again going to keep them more active and hopefully doing the things that they want to be able to do. On radiograph, this is a better representation of it. So on the left side, you can see a patient wearing sort of the before wearing the unloader brace on the left, and then you look on the right side, you're looking at the big difference between the joint space, and as you can imagine, their functional ability is going to be greatly enhanced by wearing that brace. And so as we continue to help them move and to do their physical therapy and to do their home exercises and to do some of those things, this is going to be immensely helpful for them to be able to increase their activity. And this is just a radiographical evidence of that. Does it work? Again, so for my athletes and those in my clinic, it decreases their mechanical symptoms and decreases their pain. What does that result in? Increased knee function, increase in activity, and they're going to want to wear it more. So they're going to be more compliant with it, and because it's actually helping them. So this is the big key for me, is being able to allow them to decrease their mechanical symptoms and decrease their pain, and thereby increasing their function, activity, and the compliance is going to follow with it because of those 4 previous factors. What are we trying to do? We're trying to actually shift the load from the medial compartment to alleviate the pain. So what does this valgus unloader brace do? It's actually going to do what we said on those last couple of slides. It's going to gap that joint. And then if you look, in a lot of my patients will say, well, I'll just get a brace online, no big deal. So the valgus versus neutral brace shows improvement in the pain and statistically significant decrease in pain. And that's something that you're able to talk to your athletes and your patients in the clinic when they sometimes hem and haw about the brace and say, look, I'll get it online. I'm not sure about this. You let them know that this is not something they're able to obtain online. This is something that is made specifically for what they have versus a generic neutral brace. So that's something to keep in mind as we go through this from a patient education standpoint. Some of the other things that we can certainly talk about include hyaluronic acid biologics, which I also use in clinic in conjunction with the bracing, PRP, amniotic stem cell, DMODs. So we look at these and what are we trying to do? These are you're trying pro-inflammatory mediators, and you're looking at some newer things like, I know our pain guys are diving into a little bit of genicular nerve blocks. Not something that I do certainly in my practice, but that's something that we could kind of talk about as the future moves on. But certainly something that these are, from a cost standpoint, even from an insurance standpoint, things like the PRP, amniotic stem cells, not really covered, and you're spending a lot of money out of pocket in that regard too. So really the take-home points here for me, the treatment of knee and osteoarthritis can be done with conservative management with a multifaceted approach, as we talked about. Understanding your patient's goals and expectations when coming up with a treatment plan. I think that's why that expert consensus is such a good and useful tool, because it does take into account patient expectations and their perspective. And I think that's why that's something that would be certainly worthwhile for you guys to take a look at again, as I mentioned that, because you're able to connect with your athlete and your patient in a manner that really hasn't been done before, where you're able to look at and say, hey, these have been taken into account with patient experiences and expectations and perspectives. So really the other thing is understanding the mechanism of knee OA and how the unloader brace can support motion and help patients in that regard. So that's something that we use quite a bit. And like I said, that's standard. We talk about the unloader brace as really on their very first visit. They go and they get fitted and they try it, and then I see them back in a month and they let us know if they like it, they don't like it. But we've had really good feedback of it. So I always use this as we get going here, and I told you guys that I'm going to be in Dallas in 10 days. So one last piece of advice that I always use is that should you be lucky enough to win trophies and get into a team photo, my recommendation is make sure you get yourself in a good position for the team photo, because I promise you I was there, but our GM, Dave Noble, photo bombed pretty quick and obscured me. So I learned my lesson. So the next time I was in a team photo, this was in 2017, where we won the gold medal for the World Hockey Challenge. And I got myself in a good spot there to smile and be with the boys there. So it was a lot of fun, and hopefully we can do it again. For the under 18 World Juniors coming up here in a couple of weeks. So that's what I have from my end. I'm happy to answer questions. I wanted to make sure we left a lot of time for questions here to be able to go over some things. And these are some of the handles here. If you want to follow along, we give lectures and case reports and things we do in clinics. So you're happy, if you want to follow along, you can do that. And I'm happy to open up and answer any questions and kind of go from there. So
Dr. Garg, there's a question on the chat box.
Yeah.
I don't have much experience using these. Any difficulty getting it to fit well on overweight or obese legs? Great question, by the way.
Yeah, so great question, Nate. So thank you for that. Yeah, so the the nice thing about this, there's two things. You can get off-the-shelf bracing, and then the other thing the Össur does a really nice job is getting them custom fit. So if you have larger quads, larger thighs, you will be able to get them to customize and be able to do that. So if the off-the-shelf brace doesn't fit, Össur does a really nice job of being able to handle the different sizes and be able to get them customized. So I haven't had much issue with that, and we're able to get those fit both off the shelf and custom. So we haven't had issues in that regard.
And I think that's really a great question that comes up all the time, and you as clinicians face that all the time. And not just the fit, but then patient compliance with it, right? And that's why, we've heard over years that these braces historically were too heavy, too hot, slipped. And, and we've tried for 20 some years to address those issues in the product that now we offer. And hopefully it's a more comfortable brace, as Dr. Garg said, with the right fit with the patient. A new question, what stages of OA do you find most responsive in bracing?
It's funny. So generally speaking, we've actually had pretty good success across the board. I mean, and part of this is figuring out which brace you'd like to be able to use, and which one is sort of better for a little bit higher grade of arthritis. But even if it's really mild to moderate, I mean, I start them right away just to be able to sort of stop that progression if we can. And so realistically, I've had pretty good success across the board. I mean, if you're going to have end stage where it's multiple osteophytes and really severely varus deformity, that may be the one that is less likely to benefit from it. But like I said, I mean, if I'm making a diagnosis for arthritis in my clinic, we're starting them on a brace, and we're going to let them tell us that, hey, this is not working for me, rather than kind of going the other way around. So I hope that answers your question. So
another question for you.
Yeah.
If evaluating patients with medial knee OA and finding that they have pronated feet, is it better to start with lateral wedge insoles or medial knee unloader brace? Yeah. Or I'll add to that, or a combination.
Yeah, so that's a great question. So one of the things that we end up doing is the lateral wedge insoles tend to be sometimes for the more severe cases. What I like to do is I actually start them out in the knee brace and I send them to therapy. And we end up getting them a video gait analysis to see whether or not the brace in itself is helpful in their function, and they're able to not only use the brace and strengthen their hip, and hopefully that addresses some of their pronation or their lower leg issues. So we've done that. We asked them about getting just insoles. Again, maybe not the lateral wedge, but something for pes cavus or pes planus. We get them good support shoes. So we try to do that to help them in everyday life along with the bracing. I think that tends to be a little bit easier than just throwing in lateral wedge insoles and sort of biomechanically changing from there, rather than targeting the actual source, which is the knee osteoarthritis.
Great. Another great question. Do you find similar benefit for varus unloaded for lateral compartment OA? And just as an aside, and Dr. Garg will answer this, great question, because one of the studies out of Stedman actually looked at that and saw the same benefit. So clinically, I'll let you answer that now.
Yeah, no, so I mean, Margie read my mind. So basically it's the same thing, right? So while I said medial is certainly more common, so that's the one that we're going to see the most of by far, I get the same result from a lateral standpoint. And if you think about it, the mechanism is the same, right? And so you're still trying to gap the joint. So in terms of the lateral compartment versus medial compartment, we get the same result in terms of patient satisfaction out of them. So I've been quite pleased with the lateral component and being able to lateral offload in that regard. But to Ben, to answer your question, it just happens to be more common, as we talked about, from the medial side. So I don't see a difference between medial and lateral from my standpoint.
And the links that you'll get in this presentation and follow up will resource you exactly to those clinical published studies. And so it'll be a great resource for you to have those in your file as you look back and review things.
I'll tell you one other thing, just to add, in terms of being able to give your athletes and your patients tangible things for them to do for their arthritis. A lot of times they're going to come in and they're going to have an arthritis flare. So you can give them a corticosteroid shot that will relieve their pain in the short term. And then you start talking about, hey, here's what we're going to do to try to minimize the effect that this arthritis is having on you. And I'll tell you, they're really thankful to be getting measured and fitted for that brace, because it feels like somebody's listening to them and taking into account their pain and what they're trying to do. And as I mentioned before, if you treat these people like athletes, like we walk in there and say, hey, what do you want to get back into? Do you want to go back into tennis or golf or whatever you want to do? No problem. Here's what we're going to do for this. And they're able to get a function. And we have them walk down our hallway after they put on the brace, and they can feel that sort of tangible, noticeable difference. They're walking out of your clinic. I mean, really have, not only have you helped them just for their short-term pain, but you've given them something to help them from a longer-term standpoint that's going to help them continue to do their activities. And so we've had a lot of people walk out quite happy, just being, and either they're excited about getting their custom, or they're waiting, or they're going to take one home, and if that's what, from an insurance standpoint. So we've had really good success with it. So I'm quite happy. And I'll tell you, I was using these braces before Össur even asked me to speak for them. So this is something that has nothing to do with other than me finding something that really worked for my athletes, and then going to one of these. And this is kind of how I started speaking for Össur. It was just, hey, I was using these before you guys even asked me to speak on this. So for whatever that's worth, I mean, this was something I was using before they asked me to come talk to you guys on a Tuesday night.
Another question, couple more questions.
Yeah.
So let's see. For OA treatment cascade, where do you put bracing? After NSAIDs and before HA and steroids, or do you use them as first go or concurrent with other modalities?
Yeah, so good question. So like I said, I mentioned, so where does this bracing happen, right, in terms of my decision making? So it happens on day one, really, time zero. So we talk about weight loss, we talk about topical medication, hyaluronic acid, and again, you're not going to be able to get hyaluronic acid unless they've failed conservative management, including physical therapy, and most insurances are requiring a corticosteroid injection. So we've added on top of that physical therapy, and bracing is part of it. So that's part of our 6-pack sheet that we hand out to them and say, look, this is part of it, and you try it. If you don't like it, no problem. And Össur's been really good about working with those athletes that have some, when they, on the rare occasion that they will say, hey, this maybe isn't a good fit, but that's been so far and few between that that's why we have everybody try it, because they've been pleasantly surprised.
So this next question is one that I think we all have in our head and get asked all the time. Any tips on getting insurance to pay for these braces?
Yeah,
I'll let Dr. Garg answer, and then I'll weigh in.
Yeah, so Marge, yeah, thanks. So the big thing is really, I'm going to tell you, document appropriately. I mean, I think that's really the biggest thing. Why are you getting the braces, right? So for me, it's varus deformity, there's some level of instability, there's some laxity. So these are some of the things that I look at to make sure that these patients are qualified for getting the braces. So that's been the biggest tip that I can give you, is make sure that you're able to document appropriately and have causation and need for a medical necessity for the braces, which these athletes do meet, but you gotta make sure you document appropriately.
And I think that's a challenge more and more that you're all facing. Everybody's insurance is different, and none of you were trained in insurance. And so, the people in your office that manage that and are well educated are great resources for you with that, right? And yes, there is a copay, and that varies from person to person. But the benefit of this is it's so great, and many of your patients are paying much more out of pocket for some of the other treatments that they choose. So contact your local. We have a network of local people, as do all the companies you work with, that can really assist you with this. and please reach out to them to ask for help, because it's a complicated world with reimbursement for sure. Another question for you. In regards to evaluating and fitting the brace, who in your office measures and fits the patient, or does the representative help with logistics?
Yeah, so good question. So basically, I worked in Chicago before I came to Nashville, and Össur did a really nice job. I know Eric Susi's my guy up in Chicago, and he would come and help and get those patients fitted here in Nashville. And then we had a DME specialist in the office as well in Chicago. And then I have one here in Nashville. I'll tell you, this is something that can be done in the office that can actually be a revenue generator for the office, where you're actually even hiring somebody to come in and fit, depending on what your volume is, to be able to fit them in the office and be able to bill them and to be able to do that. So this is something that you could look at in terms of not only getting an extra hand, but maybe something from a revenue standpoint that can help your office. So that's something to look into. I'm happy to have a discussion offline if you'd like, in terms of what that looks like. And but that's something that you can look at, is having somebody come in and be part of your office staff that's actually not only going to pay for themselves, but actually going to be a revenue generator depending on your volume. So hopefully that answers your question, Jacob.
And I'll add to that, Dr. Garg. So many of you who know me know that I'm a certified athletic trainer and past president of the NATA, and the perfect clinical assistant for you for DME is the certified athletic trainer, who really is skilled in working with you on the sidelines, and also now skilled working with you in the clinic. And they, in many, many practices that we're very familiar with, totally manage the DME and totally take care of all of that for your patients. And then also see patients and either bill incident to or bill directly for athletic training services. All of that has evolved so much over the last 20 years that that for a clinical assistant with multi-skills and who really understands you as a partner with them as they've grown up with you in athletics is a good option to consider also.
I mean, to Margie's point, I'm lucky enough to have my athletic trainer and my right-hand person come with me from Chicago to Nashville. So she came with me. So that's all I know is athletic trainer from fellowship at Andrews. That's all we used. And in terms of support staff, and they are vital for, I mean, I can't do what I do without them. So wholeheartedly agree with that.
And actually, as a resource, we have a great network throughout the country. And, if you need resources on how to find that person or how to find the best, credentials of who you should be looking for, please reach out to me. And AMSSM has my information, and I'm happy to help you with that. So here's a tough one. We have temporarily lost the contract for Medicare for our braces. We weren't the lowest bidder. We are pursuing, but is there a way our patients can get the Össur unloader braces for a price between at cost and the insurance cost? So I think, and Dr. Garg, you can answer this also, but I think this ties in to competitive bidding that Medicare enacted the first of the year. So yes, there are those bracing resources that are part of the competitive bidding process that have won those bids, that Össur products are absolutely offered and integrated in the full menu of bracing in that competitive bidding programs that have been approved. And Dr. Garg, I'll turn it over to you on that.
Yeah, I mean, the same thing. I mean, I think anytime I have questions about that, I certainly call our rep here and try to get that squared away. So we've had really, really good support. And I think that's something that we end up leaning on our colleagues, certainly at Össur, to be able to help us in that regard. So we generally turn that over to them and to be able to say, hey, look, here's our situation, what can be done about it, and they've helped us out quite a bit. So.
And I think all of the companies that you have close relationships with, we're committed to finding answers for you. We might not have it at that minute, but we're resources for you. We know there are so many challenges in your practice not just patient care, but the business of medicine that you might not have the answer for, that you have a gap in trying to, like, what's the best solution? And that's where you need to lean on the industry relationships that you have to really, to let us and others help you solve those problems while you're working really hard to keep your patients active, mobile, and achieving their full quality of life. Any other questions? The questions have been great, and really appreciate that, because in this virtual setting, we know how hard that is to get interaction, but in the last year, we've all learned a lot, and you've all done a great job tonight in asking some really critical questions. Anything else? Let's see. Yeah, thank you. And just a comment from somebody on Dr. Deck actually agree. We've had several ATC position extenders. The additional skills benefit with the aspect of OA and bracing, and Össur has been helpful in interfacing with getting the braces addressed. So thank you to the partners and support that we have.
Marge,
yes.
I am in the car. Can I ask a question, because I can't type now?
Sure.
This is Cindy. Thank you very, very much for your support of AMSSM and our members. You know, it's been years, decades of your support, so we really appreciate it. My quick question is about the bracing for hip OA and whether or not there's been any advancement in terms of the hip bracing that Össur provides for hip OA, because we're seeing so much more hip OA than before as well. And I know, Dr. Garg, you didn't address that issue, but can you maybe address the products that are available out there for hip OA? And I'll go on mute. Thanks.
Oh, absolutely.
A whole nother lecture on hip OA, yeah. Because I do that lecture as well. I mean, that's for sure. So I use, certainly this one was specific for knee, but I use hip OA quite a bit, hip OA unloading braces in my office quite a bit as well. So I think we were one of the first ones to use it up in Chicago. Even I know when it first came out, I think Marge and the gang sort of came and showed me that as something that I was able to utilize in Chicago several years ago. So and I don't know, and even there's always talks about doing different things and in terms of from a hip unloading standpoint, and so.
Absolutely, and you know, the hip unloader brace, those of you who are familiar with it and those not, is a bit of a different technology. It doesn't unload in the same way as the knee unloader, but it's certainly a very, very unique product. We were the first to enter the market with that product with relief for non-surgical hip OA. And the biggest key, and it is a great product, is patient selection, as is with everything that you're talking about here. With knee OA, it's patient selection in terms of what is the best treatment protocol or what is the best adjunct therapy for you. And that is the same with the hip unloader. Very successful patient selection, great feedback from patients who have worn it. It looks a little intimidating. It looks like bike shorts, right, Dr. Garg, when you put them on? But actually, women have said, oh my gosh, it's like Spanx. This is great. I'll wear this under a skirt, and they do. So, you know, if people...
pull up a picture of it just so you can share it.
Great, thank you. People with hip pain, if they're in pain and this relieves their pain, and it does with the right patient selection, they will wear it. And there's so fewer options with hip pain, right? Thank you. Yeah, with hip OA, it's like with knee OA, you have a whole toolbox. With hip OA, not so much. And so this is something that really add to your toolbox. And we'll send you a link also to this product line and more information since the question came up. Thank you.
Yeah, just a quick thing on this. I mean, just from an educational standpoint, since we're all here, what this does, you're actually adding compressive forces. And along with that counterforce strap, you're actually gapping that joint as well. So not only do you get the compression aspect of it, you're actually gapping that joint as well. This can be helpful for labral tears. This is something I'm looking at also for glute med tendinopathy, to be able to use that post 10X procedure that I do. So there's a couple other things that from this standpoint that this could be used for to certainly help in that regard. So that's a good question from Cindy, just something completely that would be beneficial, not only from, as we talk about unloading just in general from the knee, but certainly the hip standpoint, which I use quite a bit as well.
And again, goes back to your resources and finding the right resources for you to provide this information. And I know time is really of essence to all of you as you manage your patient load during the day. But people are always there to help, and we're always there to provide resources for you.
Yeah, I mean, honestly, if you guys get in trouble, call me because I'm happy to help you too. They've been nothing but a big support, and anytime I've had a question or anything like that, they've been super, super responsive. This is a pretty good company. Really great company to work just from a customer service standpoint. So I've had nothing but great things to say about it.
Any other questions as we wrap up? Yeah, it's really great to be able to be with you on the front end of the meeting and know that you have so many courses coming up and so much online Zoom work coming up that it's great to kind of catch you at the beginning when you might be a little fresher with the Zoom. And again, your questions are great, and we'll have them all in text and for us, and so we'll follow up on those that ask for specific resources in your area. We'll definitely be in touch and follow up with those.
Yeah, wonderful. And like I said, anybody wants to reach out to me, happy to do it. Margie's got my info, so you can certainly do that, and happy to help in any way that I can. So
look forward to being with you throughout the meeting. We'll be in the Össur exhibit area, and virtual exhibits, we make it happen, right? And then there are a few other functions that I'll see you all at. So thank you again for doing a great job, AMSSM, to be a great partner with Össur and with our key opinion leader, Dr. Garg.
Yeah, thanks guys. Thanks very much for having me. I appreciate it.
Great. Have a great rest of your evening. Thank you.